water. I'll go ahead with the history. Mrs. R, 25-year-old housewife from Kallur, Chittur, Andhra Pradesh, presented to the emergency department complaints of fever for 1 week, generalized myalgia for 1 week, knee and ankle joint pain for 2 days, and rash for 2 days. Elaborating the history, the fever she was apparently 1 week back when she developed high-grade intermittent fever with chills, which resolved with medication. It was associated with generalized body ache, which was there for 1 week, bilateral knee and ankle joint pain 2 days. There was no other joint involved. Then she developed small pinpoint rash all over the trunk, back, arms, and legs. There was no association. The rash was pinpoint to start with, and slowly it became enlarged and it became painful. There was no bleeding associated. There was no pus discharge or any serious discharge from the rash. Negative history-wise, she has no others. No cough, no dyspnea, no chest pain, no loose stool, vomiting or abdominal pain. There was no headache or altered sensorium. Examination was vital-wise. She was tachycardic, BP and heart rate, respiratory rate was normal. Systemic examination, she had no significant finding. There was no neck stiffness, no hepatosplenomegaly. Cutaneous examination-wise, there was erythematous, rectiform purpura noted over the upper and lower extremities with distal predominance extending to involve the palms and soles. Retiform necrotic purpura was noted over both knee joints. Similar purpura was noted over left forearm and arm. There was a resolving erythematous macular purpuric lesion over the trunk. No eschar was found, but there was a blanching rash over the upper back. There was bilateral upper and lower limb pedal edema. So this is the image we have taken with consent of the patient. So this is a necrotic purpuric rash which was present on the knees of the patient. Any guesses what it could be? And luckily,
any of the first year postgraduates would like to? Yeah, go ahead. Just loudly because we are recording.
Yeah, so luckily yesterday evening also we got a similar case. Mr. A from Velo, he presented with fever with chills, with swelling of upper and lower limb with erythema and pain. Yesterday night when we examined, there was no purpuric rash per se, but today morning when we went and examined again, he had, this is also taken with the consent of the patient, he had purpuric rash over the thighs, both thighs, with erythema and swelling of both legs and hands. So the syndrome complex we found is syndrome is fever with purpura fulminans. So I went through CMC studies which are done here about purpura fulminans. Coming back to our patients, the first patient which was there. So differential we had considered was some rickettsial infection, probably spotted fever. The second was some bacterial infection. It could be meningococcus or staphylococcus. Third, it could be autoimmune disease, Neisseria rhapilla. And other causes which can cause purpura fulminans are like some insect bites, scorpion or snake bites. Acquired protein C or protein S deficiency, which could be due to warfarin drug induced, or there can be heparin induced necrosis at the site of injection. So for our patient, the investigation wise, she presented with thrombocytopenia with mild elevation of transaminases with normal coagulation profiles. There was no other no other renal involvement. We did serology for spotted fever, which came back positive, and blood cultures were negative. So I want to talk about purpura fulminans. Purpura fulminans is a rare vascular disorder characterized by fever, shock, multi-organ failure, with rapid development of hemorrhagic skin necrosis. It is usually associated with dermal vascular thrombosis, vascular collapse, and disseminated intravascular coagulation. It may result from hereditary or acquired protein C deficiency or activated protein C deficiency. There are three types. Two are neonatal. One is neonatal purpura fulminans, one is idiopathic, and third is acute infectious purpura fulminans. So in CMC, there was a study done from 2000, case study done from March 2005 to March 2017, where they looked about the causes of acute infectious purpura fulminans. I just put the The history was fever with confusion and headache, the common history of the patients. This was a table which they had found. Most of the patient had fever, confusion, and headache on presentation, out of which they did all the evaluation. And in 2 patients, the CSF grew Neisseria meningitidis, and 5 patients came positive for rickettsial infection, which is spotted fever was positive. And in 1 patient, there was dengue was positive in 1 patient. And autoimmune worker, 1 patient, or APLA was positive. So this is the gross what conclusion positive for acute infection for purpura fulminans. Then there's a second study which I saw. This relates purpura fulminans with spotted fever. Like they did a case study of 48 people, out of which they selected 7 case studies which had positive or probable spotted fever with purpura fulminans. So this is the table which shows the clinical features, treatment, and outcome. So every patient presented with fever, rash. Rash was either a proper purpura fulminans or acral purpura fulminans or some purpuric rash, which few patients went into have gangrenes. So most and serological wise, most of them tested positive for spotted fever. Only 1 patient did not test serologically positive, but Buffy code PCR was positive. So at the end, I would like to coming back to our patient. She was diagnosed spotted fever. She did not have any severe organ involvement. We started on doxycycline for a course of 7 days. She did not develop in any, the rash did not form into any gangrene, and there was no changes. There was severe arthritis, which was managed with round of paracetamol. At the time of discharge, she had improved clinically, and she was hemodynamically stable. So my learning point of this presentation is the present clinical awareness and presentation of rickettsial infection, which can present as purpura fulminans, and prompt diagnosis and initiation of treatment in rickettsial illness has favorable outcomes. The other causes that can be for purpura fulminans is meningococcus, staphylococcus sepsis, and scrub typhus.
Let's give him a hand. Thank you. We have time for 2 questions. Anybody would like to ask questions?
What was the diagnosis of the second patient?
I'm just admitted yesterday night. So today morning only we saw the purpura. So we have.
You started that patient on doxycycline?
Yes, ma'am. We started the patient on doxycycline.
Is there any other organ system involved in the first patient?
First patient. No, LFT was a mild transaminase elevation was there. No other system involvement was there.
Actually, the box is also anyone is very much of spotted fever. Maybe this season, the box is so rash. That's what's they will probably have high further enzyme activation, high from the second. For spotted fever, they don't give some better
Okay, thank you. One more hand. Yeah, sure.
When you take menstrual
So the patient presented with fever, with headache, and confusion, along with.
Sure. So the one sometimes the lesion, the particular lesion, if you aspirate it and do a gram, you can make almost a bedside diagnosis of your coffee. Pulmonary illness can lose the patient. And the rash is more diffuse.
M5.